procedures, and most important of all, decrease health costs and health burden for both the patients as well as the healthcare system. Next. However, the oral route is not preferred in neonates because there are concerns about oral drug absorption. Also, there is difficulty in distinguishing between neonates with and without bacterial infection. Culture positive sepsis is less common in neonates, and hence in most cases, antibiotics are started based on clinical symptoms and inflammatory markers which are often non-specific. Now, what are the evidences that are available about oral versus intravenous route of antibiotics? Next. So Gwen et al. Evaluated the pharmacokinetics and efficacy of antibiotic switch in a small group of neonates with probable or culture-proven group B streptococcus infection, and they found that the therapeutic levels of amoxicillin in these babies were in the predetermined therapeutic range, and hence oral antibiotic therapy could be an efficient alternative to intravenous antibiotics in neonates with probable bacterial infection. Next. A study was carried out by Banzoni et al., which evaluated switch therapy in full-term neonates with presumed or proven bacterial infection. And they also found that a switch to oral antibiotics after 3 days of intravenous therapy in patients whose physical and clinical parameters indicated disappearance of infection could significantly reduce the length of stay in the NICU and also significantly increase the breastfeeding rates without having any negative clinical impact. Next. So what was the pre-trial research done? Next. Before the RAIN study was started, the authors conducted a systematic review and meta-analysis of all the studies on the use of oral antibiotics that had been done so far. They concluded that there were many large clinical trials that had been performed in low and middle income countries which evaluated the use of simplified oral antibiotic regimens in healthcare settings where referral is not possible. These studies showed that the use of oral antibiotics is safe and efficacious. So there were about 31 studies which met the inclusion criteria of the meta-analysis carried out by the authors. And they also found that the oral antibiotics which were administered to the neonates were well absorbed and resulted in adequate serum levels which were judged by MICs of the relevant pathogens. However, they concluded that there was a need for additional well-designed trials in different settings, particularly in the high-income settings. Next. So why was this trial conducted? The findings of large-scale trials which were carried out in the low and middle-income group countries could not be extrapolated to high-income settings, mainly because in these previous trials, infection was suspected on the basis of clinical symptoms only and no additional diagnostics were used. The RAIN study was thus the first clinical trial in a high-income setting in which the safety and efficacy of early neonatal IV to oral antibiotics which was evaluated. So the hypothesis of the study was that oral antibiotic therapy is not inferior to intravenous antibiotic therapy in terms of reducing reinfection rates in neonates treated for a probable bacterial infection. The null hypothesis stated that the difference in reinfection rates in the oral antibiotic group would be greater than 3% that of the intravenous group. This was a multicentric randomized open-label non-inferiority trial carried out at 17 teaching hospitals in the Netherlands with 19 recruitment sites. The trial was registered with the National Clinical Trial Registry. The funders of the study had no role in study design, data collection, data analysis, interpretation, or writing of the report. Now, what is the difference between a superiority trial, a non-inferiority trial, and an equivalence trial? A superiority trial is designed to show that a new treatment is better than an existing treatment or placebo. In equivalence trials, the goal of the trial is to demonstrate that the treatment with either therapy is equally good. A non-inferiority trial, on the other hand, shows that the new treatment is not unacceptably worse or non-inferior to the existing treatment. Next. So basically, this is a diagram. And if you consider the difference between the effect of the existing treatment and the new treatment as M, for an equivalence trial, the effect of the new treatment will lie in between minus M to plus M. For a superiority trial, the effect of the new treatment will be in between 0 to plus M, or it will be more than plus M. In contrast, for a non-inferiority trial, the effect may either lie between minus M to plus M, or it may even be more than plus M, but it will never be lower than the non-inferiority margin, that is minus M. To simplify, considering A as the new treatment and B as the existing treatment, for a superiority trial, A will be greater than B. For an equivalence trial, A will be equal to B. And for a non-inferiority trial, A might be equal to B or superior to B, but it will never be inferior to B. Coming to PICOT, the population which was included in the trial were neonates with a postmenstrual age of minimum 35 weeks, with a postnatal age of 0 to 28 days, and a body weight of minimum 2 kgs, who had a probable bacterial infection defined as clinical symptoms and/or maternal risk factors and elevated inflammatory markers for which empirical broad-spectrum antibiotic treatment was initiated and needs to be continued for more than 48 hours. Additionally, the neonates had to be clinically well and had to tolerate oral feeding without overt vomiting. Neonates with a proven bloodstream infection, neonates with absence of blood culture, those with severe localized infection or severe clinical sepsis, those who required continued need for a central venous line, those with severe hyperbilirubinemia requiring exchange transfusion, and cases in which the parents were unable to administer oral medication were excluded from the study. Next. Neonates allocated to the intervention group were switched to an oral suspension of amoxicillin and clavulanic acid in 3 divided doses from day 3. And neonates allocated to the control group were continued on intravenous antibiotics for a total of 7 days. Next. The primary outcome was cumulative bacterial reinfection within 28 days after treatment completion. This was defined as presence of clinical symptoms of infection with fever or hypothermia and elevated inflammatory parameters like CRP or procalcitonin with a need for prolonged antimicrobial therapy beyond 48 hours. The secondary outcomes which were evaluated included clinical deterioration during study intervention, duration of hospitalization, readmission rate, and quality of life, which was judged on the basis of number of painful procedures, breastfeeding pattern, sleep quality, gastrointestinal symptoms, and the number of IV cannula reinsertions in the first month after treatment completion. In addition to these, the adverse events in both the groups were also evaluated. This study was carried out in between 8th of February 2018 to 12th of May 2021. The neonates were randomly assigned 1:1 to the intervention group or the control room using block randomization method with block sizes of 2 and 4. Next. Coming to types of randomization, there are 4 types of randomization: simple randomization, block randomization, which was used in this trial, stratified block randomization, and dynamic or adaptive random allocation. Next slide. So this is a slide which represents block randomization. So you can use different sizes of block ranging from 2, 4, 6. Usually a block size of 4 or more is preferred because if you use a block size of 2, there is a chance of selection bias. So in this example, a block size of 4 was used and there were 2 groups in the study, the intervention group and control group. So with 2 groups and a block size of 4, 6 combinations were possible. Thereafter, random sequence was selected. Like, for example, here it was 1, 3, 4, 4, 3, 6, 1, 2, 5, 2, and so on. So the first block was 1. So the first 2 patients, which are black in color, will be allocated to the intervention group. The next 2 patients will be allocated to the control group. The next number in the sequence is 3. So this is the third combination. So here the first person will be allocated to the intervention group. Next 2 will be allocated to the control group. And the last person will again be allocated to the treatment group, and so on. The advantage of block randomization is that it ensures equal distribution of participants in all the groups involved in the study. Coming to masking, considering the nature of treatments, masking of patients was deemed unethical and was therefore omitted. The local study teams performed outcome assessment and were therefore not masked to treatment allocation. The study statistician was unaware of treatment allocation. So types of blinding. The first type of blinding is unblinded or an open label study, and the RAIN trial was an open label study. Next comes single blinding, in which only the participant is unaware of the allocation. Double-blinded trial, in which both the participants and the clinicians are unaware of the allocation. And triple-blinded, which is the ideal type of blinding, in which the participants, the clinicians, and the data analyzers, all three are unaware of the allocation. An overview of the procedure. So basically on day 1, newborns who were suspected to have a bacterial infection following risk assessment, in these babies, inflammatory parameters, that is CRP or procalcitonin, and a blood culture was sent, and intravenous antibiotic therapy was initiated as per the national protocols. At 24 hours, the inflammatory parameters were again repeated, and a flash of the blood culture was traced. And all those patients who had an elevated inflammatory marker at 24 hours, but with a negative blood culture, were considered eligible for the RAIN study, and the patient information and consent was handed over to the patients. All those who were deemed eligible for the study were then randomized into 2 groups, the oral intervention group and the intravenous control group. Babies who were in the oral intervention group, 30 of them were also subjected to pharmacokinetic studies to assess the therapeutic levels of amoxicillin that were reached after oral administration. And after all those babies who were able to tolerate at least 3 doses of oral amoxicillin were discharged on day 4. In contrast, all those babies who were included in the intravenous treatment group continued to remain in the hospital for the 7 remaining days of antibiotics. On day 5 and day 14, a telephonic interview of the participants was conducted by the local investigators. On day 7 and day 21, an online survey was conducted. And on day 35, all the patients were expected to follow up in the OPD for further assessment. Next. Coming to statistical analysis, evidence on reinfection rates following the culture-proven infection were used, and a reinfection rate of 1% was assumed, and a non-inferiority margin of 3% was decided upon. Now, a non-inferiority margin of 1 to 2% would have been more desirable, but this would have increased the sample size exponentially, and this would have deemed the study non-feasible, and hence a non-inferiority of margin of 3% was decided upon. A sample of 231 patients per group would be required for 90% power at a one-sided alpha level of 0.025. Assuming a dropout rate of 10% and the need for recruitment of additional patients for pharmacokinetic study, a sample size of 550 was decided. However, no dose adjustments were needed in the population, and hence no patients required to be replaced. So the final sample size was 510. A p-value of less than 0.025 was considered statistically significant for primary outcome analysis. For secondary outcomes, chi-square test or Fisher's test were used to analyze binary outcomes, and Wilcoxon rank sum test was used for continuous data, and a p-value of less than 0.05 was considered statistically significant for the secondary outcomes. Now, this is an overview of how the trial went about. So there were around 829 neonates who were assessed for eligibility. Out of these, 242 parents did not give consent, 77 were not invited, 15 were too late for inclusion, there were 13 who had language barrier, 6 had logistic issues, 8 had social concerns, and in 35, the reason is not known. So of the 510 neonates which remained, half were randomly assigned each to the oral intervention group and the intravenous control group. Of the 255 patients who were allocated to the oral intervention group, 2 withdrew treatment and hence were treated with standard intravenous therapy. Of the remaining 253, 1 did not fulfill inclusion criteria as the inflammatory markers at 24 hours were normal. There were 3 patients who had to discontinue treatment because of serious adverse events. 1 patient had vomiting and feeding problems. 1 had a pre-existing elevated gamma-glutamyl transferase level, and in 1, the cause of discontinuation was not known. So there were a total of 246 patients included in the per protocol analysis in the oral intervention group, and there were 252 patients included in the intention to treat analysis in the oral intervention group. Coming to the intravenous control group, there were 2 patients who withdrew treatment. Of the remaining 253, 1 was lost to follow-up, and there were 49 patients who discontinued intravenous treatment, of which 33 received oral antibiotics, 3 received intramuscular injections, and 13 did not receive any form of treatment. Thus, in the controlled intravenous group, there were 203 patients included in the per protocol analysis, whereas the intention to treat analysis included 252 patients. Results. So coming to baseline characteristics, the characteristics which were matched in the 2 groups included gender, gestational age, early onset sepsis, birth weight, nulliparity, incidence of twins, the mode of delivery, group B streptococcus status, incidence of prolonged rupture of membranes, incidence of maternal fever, suspected intrauterine infections requiring antibiotic treatment, clinical symptoms at the onset of infection, which were again divided into respiratory, circulatory, gastrointestinal, neurological, temperature instability, and behavior changes. Next. Need for any respiratory support. The C-reactive protein elevation at 0 hours and 24 hours, as well as the mean CRP levels in both the groups. Similarly, the incidence of elevated procalcitonin at 0 hours and 24 hours, as well as the mean procalcitonin concentration at 0 to 24 hours, and CSF culture and urine culture. Next. It was found that both the groups were comparable with respect to their baseline characteristics. Coming to baseline treatment characteristic, important points were that more than 99% of patients who were allocated to the oral intervention group tolerated the oral suspension. Similarly, 98% of the patients allocated to the oral intervention group were able to complete full course of treatment, in contrast to 80% in the intravenous control group. Coming to primary outcome analysis, it was seen that in both the intention to treat population as well as the per protocol population, the difference in the cumulative reinfection rate at day 28 of life was negligible, with a p-value of 0.0001, which was statistically significant. Next. Coming to the secondary outcomes, it was seen that in both the intention to treat population as well as the per protocol population, the median duration of hospitalization was much lower in the oral amoxicillin clavulanic acid group as compared to the control intravenous antibiotic group. The mean duration of hospitalization was 3.4 in the oral group, in contrast to 6.8 days in the intravenous antibiotic group. And this difference had a p-value of less than 0.0001, which was statistically significant. Also, in the intention to treat population, it was seen that protocol violation in the intravenous control group was 21% in contrast to 7% in the oral intervention group. And this difference was also statistically significant. A number of adverse events were analyzed in both the oral intervention group and the intravenous control group. And this included vomiting, changes in defecation pattern, rash, hyperbilirubinemia, oral candidiasis requiring treatment, excessive crying, elevated liver enzymes, anemia with need for oral treatment or transfusion. And it was seen that there was no difference in the incidence of adverse events in both the groups. To conclude, this trial provided evidence that early intravenous to oral antibiotic switch with amoxicillin clavulanic acid is non-inferior to a full course of intravenous antibiotics. The cumulative reinfection rate at 28 days did not differ between the intervention and control groups. There was a significant reduction in length of hospital stay in the oral intervention group. As I have mentioned before, it was 3.4 days in the oral intervention group in contrast to 6.8 days in the intravenous group. And contrary to previous concerns, the oral formulation was well tolerated by most neonates. In 49 neonates in the intravenous antibiotic group, it became increasingly difficult to gain intravenous access during the treatment course, and they more often substituted with oral treatment. This was in contrast in the oral group, when only 6 neonates could not complete the entire treatment course. There was no increase in incidence of adverse events in the oral intervention group. Limitations of the study: only those neonates with a probable bacterial infection, which is also known as culture negative sepsis, were included in the study. This was an open label study. Any event occurring in the oral intervention group at home required readmission and hence was reported as a serious adverse event. And the antibiotics that were used in this study were as per their local guidelines and policies. So basically, to conclude, an early intravenous to oral antibiotic switch with amoxicillin clavulanic acid is non-inferior to a full course of intravenous antibiotics in neonates with probable bacterial infection, and also is not associated with an increased incidence of adverse events. So the take-home message for today is that early switch to oral antibiotics in stable culture-negative neonates with clinically suspected bacterial infection is a feasible option in the Indian scenario, where a large number of neonates remain admitted in the NICU only for completion of intravenous antibiotic course. Oral antibiotics can be safely administered at home, and this eliminates the need for hospitalization and hence is more cost-effective. This would help to reduce the health-associated burden not only for the parents but also for the healthcare system, and hence should be practiced in all cases where strict follow-up of the patients can be ensured. Coming to the CONSORT adherence guidelines, it is seen that this study satisfied almost all checklist items in the CONSORT adherence guidelines, and hence this is a good study and can be extrapolated in clinical practice.
Are you done? That's
Yes,
it?
sir.
Okay, perfect. Well done. Great presentation, Maushmi. I think it's a very important study because, I think duration of hospital stay is an important outcome. Also, need for IV access, difficult IV access. That is something also we struggle a lot. Duration of antibiotics is another sort of a session and topic of discussion, how long you should give. 7 days, 10 days, 14 days, all those based on culture positive versus non-culture positive. But this shows some light, some hope where we can try discharges babies early, especially the culture negative babies where, we want to complete the course. We can switch them to oral and change them to, and then discharge them early. But again, this is a first study, and I'm sure many more studies will come. And I think we might switch. So, Moshmi, I mean, before we take on questions, so what are your take on? So, do you think in your unit you would like to change this policy and implement, or what's your take? Yeah, you gave some take home message, but for everyone,
Yes.
yeah,
Okay.
transition to the
So
practice.
in our NICU itself, like I have seen, like currently I'm working in the outborn section, and we get many babies who are referred to us, and in most of these cases, blood culture either has not been sent or it has been sent, but it is negative. But the inflammatory markers like CRP or procalcitonin are elevated, and hence the baby has already been started on IV antibiotics and they have continued with the IV antibiotics. But clinically, if we see, most of these neonates do not look that sick. And I feel in cases where if we are able to follow up the inflammatory markers, repeat a CBC, CRP, or procalcitonin after a few days, a switch to oral antibiotic therapy may be practiced. We can implement that. But in cases where the follow up is not good, or there are the diagnostic facilities are not available to repeat the CRP or procalcitonin, in those cases I feel it is better to keep the baby hospitalized and give IV antibiotics for 7 to 10 days depending upon the clinical condition of the baby.
Perfect. There are questions, couple of questions. So, any risk of increasing neck by using oral antibiotic? Cause there can be change in gut flora, especially in preterm babies. You want to take on, Moshmi? I'll support with my answer, but you want
Okay.
to try that?
So, sir, actually, this trial was carried out in term and late preterm babies, and there is not much evidence about the use of oral antibiotics per se in very preterm to extreme preterm babies. So, more research is required, more trials are required for the same.
Sure. So, I mean, it's a very valid question, important question. I don't think it's oral versus IV. Even the IV can cause wiping up of the flora and can cause sort of growth of abnormal bacteria and more resistance bacteria. In fact, we had done a meta-analysis, which in fact, we are trying to update it and publish that if you give prolonged initial antibiotics, and longer duration of antibiotics that is associated with neck. It is not IV versus oral, because both will kill the normal flora. And in fact, contrary, there are some evidence coming that some oral antibiotics might be, it's like gut preparation we do. Some kind of that evidence is evolving now. Oral antibiotics might be helpful, but currently the evidence is not for anything. But certainly prolonged antibiotics and broad spectrum antibiotics should be avoided, and those are the ones which actually are bad for developing neck. And contrary, following that, there's a question that do they need additional probiotic? Probably yes. In fact, there's no point in starting probiotics and then you're on broad spectrum antibiotics for long, then it's just not going to help. So I think the whole idea is stopping the antibiotics early, 72 hours, 48 hours. And I know probably moving towards 24 hours in that centers. But I think changing to oral might be a good way forward. Now, elaborate randomization. I think you already did, but do you want to comment, Moshmi, on randomization?
Yeah, okay. So basically, as I've already discussed in that slide, there are 4 types of randomization. Simple randomization. Now, this is the simplest form of randomization. So this may be as simple as tossing a coin and then deciding if it is head, then that person will go to one group, and if it is tails, then that participant will be going to another group. Or you can use a computer generated sequence. But the problem with simple randomization is that when you have a smaller sample size, say, then there is a chance that there might be unequal distribution of participants in the 2 groups. So next, coming to block randomization, which I already described in this example. So you can use different block sizes, 2, 3, 4, 5, 6. It is advisable to use a block size of 4 or more, because it reduces selection bias. Suppose you are using a block size of 2, then it just leaves you with 2 possibilities. So there is a chance of selection bias. So in this example, if you see, I have used a block size of 4. In our trial also, they had used a block size of 2 or 4. And then depending upon the number of groups. So in this example, they had only 2 groups, intervention group and control group, but you can have more number of groups. And then using a block size of 4 and 2 groups, you will have a total of 6 combination sets. Then you take any sequence. This may be a computer generated sequence like 1, 3, 4, 4, 3, 6, like that. So your first number is 1. So it indicates combination 1. So combination 1 has first 2 participants allocated to the intervention group and the next 2 participants allocated to the control group. Then the next number that comes is 3. So you use combination 3. So the first participant and the last participant will be in the intervention group and the middle 2 participants were in the control group. So basically block randomization ensures that equal participants are distributed in all the groups. Next, you come to stratified block randomization. So this goes one step ahead. So in addition to block randomization, what they do is they stratify the patients as per covariates or variables like maybe gender or gestational age, like less than 28 weeks or more than 28 weeks, or even like certain variables like whether the baby had a ruptured or premature rupture of membranes or did not have. Like those in addition to block randomization, there will be stratification of the patients based on the covariate or variable. And the last type which I had discussed, which was a dynamic allocation. Now this is the most sophisticated form of randomization. So here what they do is, before allocating any participant to any particular group, they will see the distribution of patients in that group. And for example, you want patients to have equal number of preterms and term babies. So they will see whether each of the groups, before allocating a participant, whether in the pre-existing participants, each of the group is having an equal number of preterms and terms or not. So if they find a particular group which is having less number of preterms and more number of terms, and if the next participant is a preterm, then that participant will be allocated to that particular group. So the last form of randomization will ensure that there are equal number of participants in all the groups, plus all the participants like in the groups are well matched. So that is the most sophisticated form of randomization.
Excellent, excellent. I think that's a good explanation. We're going to finish in 1 minute, but there is one more question somebody asked, so we can, those who are interested, please log back in. But just to add on what Moushami said, I think best is to do computer generated randomization if it's available in your center, and that uses the best principles for randomization. So if you're planning a big RCT, probably need to have a way of randomizing. If you go for, the ways like days of or flipping the coin, the simple way, then the trial becomes quasi-randomized. So randomization is the most important thing, and the blinding is the next important thing in a randomized control trial. So that's attention has to be paid on that. Otherwise, the quality of the study goes down, and even like, in the meta-analysis, these trials sometimes don't get included because of the significant bias arising in randomization or blinding. So with that, we'll just log off and log on. I think we'll close in next 10 seconds and then you can log on. Till then, if there are only one question is there, please describe per protocol and ITT analysis. So
okay.
To answer that.
So there was a slide. Basically there